Hello. So welcome to this session where we are going to be looking at risk of bias and design justification. So in this particular mini session, we're going to be looking at risk of bias in parallel cluster randomized trials. So as a quick recap, so we've heard that cluster randomized designs require a larger sample size than those designs where we use individual randomization. And we've also heard about the perceived benefits of cluster randomization. So they're aligned with the pragmatic trials agenda, they can provide logistical benefits, and they're essential when we are evaluating cluster level interventions. So those are the reasons why cluster randomized trials are used in evidence-based medicine, despite the fact that they need a larger sample size than individually randomized trials. But we also heard that cluster randomized trials can be conducted in a variety of different ways. So they're commonly used to evaluate individual level interventions. They might include post-randomization recruitment, or they might not include any direct participant recruitment. And it turns out that particularly these three things here, become potential causes for concern and heighten the risk of bias in cluster randomized designs. So in this session, we're going to be looking at these things in more detail. So the objectives of this session are, first of all, to outline the risks of bias that can arise in parallel cluster randomized trials as defined by the Cochrane risk of bias tool. So just as a recap, this is about the risk of bias for internal validity, and we're not going to concern ourselves here with external validity. And then thinking about these different types of biases that can be particularly prevalent in parallel cluster randomized trials, we're going to outline some recommended prevention and mitigation strategies to try to prevent the most common sources of bias that arise in cluster trials. And then finally, we're going to look at some empirical evidence for risks of bias in parallel cluster randomized trials. That's just having a look to identify what proportion of current cluster trials are at risk of bias and why. So in this session, we're going to look at only parallel cluster randomized trials, but in later sessions, so particularly session 2C, we're going to look at risk of bias in other designs, such as a stepped-wedge cluster randomized design. So the Cochrane risk of bias tool classifies risks of bias of cluster randomized trials according to these 5 domains which are listed here. The first is a domain 1, and this is bias arising from the randomization process. Domain 1B is concerned with biases arising from the timing and identification of recruitment of participants. Domain 2 is around biases due to deviations from the intended intervention. And domain 3, biases due to missing outcome data. Domain 4, bias due to the measurement of the outcome. And domain 5, biases due to the selection of the reported result. So we're going to particularly focus on 3 of those that are of particular importance in cluster randomized trials. And this is domain 1A, domain 1B, and domain 5. So over the next few slides, we're going to take a look at each of those in turn to understand what they mean and how they could be mitigated. There's also an additional domain that we're going to consider. This here has been called domain 6. We're going to call it Analytical Biases, but of note, this is not a risk of bias domain that is included in the official ROB2 tool, but nonetheless, the authors of the ROB2 tool are in agreement that this is of importance, and so that's why we're going to consider it here. So first of all, domain 1A. So this is bias arising from the randomization process. So in a parallel cluster randomized trial, Randomization refers to the process of allocating clusters to arms. Now, biases can arise if this allocation is not truly random or if it is not adhered to at the level of the cluster. Now, there are two essential ingredients for randomization to work. Firstly, it has to be truly random, and secondly, it has to be concealed at the time of recruiting clusters. And this ingredient is probably underappreciated. So how can randomization biases arise? So imagine that one of the local study coordinators says something along the lines of, they've been told that the next cluster in this randomization is going to get the new intervention. And they have a cluster that they are about to recruit into the trial, and they really want that cluster to go into the treatment arm. And if perhaps it was the other way round and they knew that the upcoming allocation was the control condition and they really wanted their needy cluster to go into the treatment arm, they might ask the investigator to hold off recruiting this cluster. Let's hold off randomizing them for a few days until they are the next cluster in line to get the treatment condition. This is known as subversion of the allocation. It's usually unintentional, but nonetheless, it can be consequential. It's quite easy to prevent this type of randomization bias. And in order to do this, we need to have a properly concealed randomization implementation procedure. So, for example, an independent person should undertake the randomization. So, for example, a trials unit or a data coordinating center. And then more importantly, the randomization must be concealed from the cluster until the cluster participation is ratified and all of the cluster levels of approvals are obtained. And essentially what we need to do is to apply the same level of rigor to the randomization process as we would in a patient randomized trial. So moving on now to domain 1B. This is biases arising from the identification or the recruitment of participants within clusters. So when identification or recruitment of participants occurs with knowledge of the treatment allocation, this can lead to differential recruitment and identification between the treatment conditions. So this is not about internal validity. This is about internal validity, not external validity. It's sometimes referred to as selection bias, but this term can be a little bit ambiguous. So we'll try to refer to it as identification and recruitment bias. So this arises when the recruitment takes place with knowledge of the treatment condition that the cluster has been randomized to. It's a concern in trials with post-randomization recruitment. But it can also be of concern in trials with post-randomization identification of patients or participants. And it's probably the most important source of bias in a cluster trial. So let's think through how it can arise. So imagine that a local PI is recruiting into the trial. They know that their cluster has been allocated to the control arm, post-randomization recruitment. And then that PI starts to think, I don't think I'm going to ask any very sick patients to participate. After all, I know they're going to get the control condition. But actually, if we want a truly randomized evaluation, we should recruit everyone who is eligible. Now, it's very hard to detect whether this type of selection or identification and recruitment bias is occurring in any individual trial. So here's an example of a baseline table in a relatively recently published cluster randomized trial. And we've got the characteristics listed by study arms. And there's some hint here that there are imbalances across the two treatment arms. So the first big red flag is a difference in the numbers recruited across the arms. But there are also other hints. So for example, the proportion of patients who have had previous chemotherapy is 26% in the one arm 30% in the one arm, 22% in the other. And there are other differences, for example, race and ethnicity. So the proportional percentage non-Hispanic white is 81% in the one arm versus 94% in the other arm. But nonetheless, even if we see these differences in one particular trial, we can never be certain whether these are truly due to identification and recruitment biases or a form of chance imbalance. But nonetheless, there is lots of empirical evidence that this type of bias really does manifest in cluster randomized trials. So first of all, when we look at baseline imbalance across lots of cluster randomized trials together, so not just one cluster trial, but we take many cluster trials and we compare the characteristics that are routinely measured in all cluster trials or many cluster trials. And it has been demonstrated that there are significant differences in the average age of participants between treatment and control conditions. Now, the same thing does not arise when the ages of characteristics are compared across treatment arms in individual randomized trials. So there's empirical evidence of baseline imbalance, but there's also lots of process evidence. So many cluster trials recruit or identify participants after randomization. Almost all do not clearly report if this recruitment was blind to the allocation. So therefore, many cluster trials do not appear to conceal the allocation from participants at the time of recruitment. There are ways to prevent identification and recruitment biases. So there are some key prevention strategies. The first is to recruit all participants before randomization, but this is not always possible. We'll have a look at some examples where it's not possible. The second is to blind the treatment conditions, again, not always possible. So then we move on to mitigation strategies. So the first is to minimize the number of eligibility criteria, only including a small number of objective eligibility criteria. And this will help minimize identification bias. And the second mitigation strategy is to recruit by somebody who is independent to the trial and who is also blind to the cluster status. This will help minimize recruitment bias. And then there are also reporting strategies. So reporting timelines of recruitment and randomization will help others to identify whether the trial could have been at risk of this sort of bias. And currently these things are reported very poorly. So moving on now to domain 2. So domain 2 concerns biases due to deviations from the intended interventions. So trials which intend to measure the effect of offering the treatment in everyday practice are unlikely to be conducted with blinding of the participant to the allocated treatment. So then we find ourselves in the situation where deviations from the intended intervention can occur. So either those in the control condition can receive the intervention condition, or those allocated to the intervention might receive the control condition. But this bias can also arise if the control arm has access to other treatments, not necessarily the active treatment that is being evaluated. And this can arise because of the perception that the allocation of that particular patient has been to the inferior arm. And this is sometimes referred to as contamination or performance bias. It can be very nuanced in pragmatic cluster trials because, after all, our interest is in the effect of offering rather than the receiving the treatment. But nonetheless, it can still arise. So let's think through how deviations from the intended intervention can arise. So perhaps a patient has been allocated to the control arm. And then their doctor thinks, maybe I will give them an extra dose of antibiotics, just in case. Whereas actually, that patient probably would not have received the extra dose of antibiotics in usual care if they hadn't have been part of a randomized trial. So there are strategies to minimize the impact of these biases due to deviations from the intended intervention. Again, there are prevention strategies. Blinding the allocation from doctors and participants will of course help. We can also conceal the study objectives from the doctors and the participants. If neither of those things are possible, then we move on to mitigation strategies. We can restrict the use of the intervention condition, make it unavailable outside the trial, and we can also educate the investigators on the importance of continuation of usual care. And then again, we can think about strategies to allow reflection on whether this bias has occurred by monitoring protocol deviations and clear reporting. And then the final domain, domain 5, is bias in selection of the reported result. So studies which do not pre-specify a primary outcome, along with its primary assessment time, are at risk of selectively reporting positive outcomes. And this can arise when either there is not clearly specified a primary outcome, the trial hasn't been registered, or there is no documented study protocol. It is possible to identify whether this source of bias has arisen. And again, prevention is always better. So again, the best practices are to apply the same principles as in a patient randomized trial. So we should register cluster trials. We should publish a trial protocol. Now, cluster randomized trials can, of course, evaluate complex interventions, and the hypotheses might cover multiple levels, and we'll think more about this in section 7.3c. So, for example, we might be interested in implementation, mediating, and clinical outcomes. But clearly specifying outcomes of importance, and so hypothesis and logic, will help to this end. So we can identify whether post-registration changes have occurred. So if we identify the trial on its reported registration site, so for example, clinicaltrials.gov, and then on clinicaltrials.gov, near the bottom of the page, there is a history of changes button under the section More Information. So here's an example of the history of changes for a stepped-wedge cluster randomized trial. And when we display the changes, so we can see the original and the current version of the outcome measures, we can see that highlighted changes have occurred over time. And so, for example, if the investigators had changed the primary outcome, we'd be able to identify this. So in summary, cluster randomized trials are and often at risk of bias. And so these are the results of a risk of bias assessment on a random sample of 40 cluster randomized trials of individual level interventions, so interventions targeting the individual. A large number of them, around 50%, were identified as being at bias because of the randomization process. Essentially, they weren't implementing the same rigor in their randomization process as we would in a patient randomized trials. This is probably easily fixable in most of these cluster trials. Around 70% of these trials were identified as being at risk of bias due to the timing and the identification of recruitment of individuals. And this arises because many of these trials had post-randomization recruitment. They were unblinded and they didn't take any steps to conceal the allocation at the time of recruitment. And we identified that this was the biggest threat to bias across these cluster trials. Other risks of bias occurred less frequently, so the deviations from intended interventions occurred relatively infrequently, as did biases due to missing outcome data. Also, missing measurement of the outcome was not terribly consequential. But perhaps interestingly, a large proportion, over 50%, were assessed to be at risk of bias because of the selection of the reported result. Again, here this likely comes or arises because cluster randomized trials don't apply the same level of rigor that we are used to applying to individually randomized trials. So they often don't publish their trial protocol, they might not register their trial on a trial registration database, or they don't clearly specify a primary or set of key outcomes. And so then overall, a large majority of cluster randomized trials of individual level interventions turn out to be at high risk of bias. And it's this type of bias that we really want to prevent. And then moving on to domain 6. So remember, this domain wasn't included in the ROB2 risk of bias assessment, but nonetheless it's considered to be an important domain or an important form of risk of bias. So analytical biases refer to biases that can arise in the estimation of the treatment effects and its confidence intervals because of misspecification of the statistical model. And in later sessions, we're going to look at in a lot more detail how analysis of cluster trials should be conducted. And we're going to learn that they must consider and allow for the clustered nature of the design, and also for a small number of clusters if they only include a number of clusters less than around 40. So we might think of this sort of bias as being a fixable fault. It doesn't necessarily require any pre-planning, but it is data hungry. So remember these two penalties of cluster randomization. The first is a variance inflation due to clustering. We refer to this as the intra-cluster correlation, or ICC. And the second is the degree of freedom correction, the correction that we have to make to the analysis methods when there are around less than 40 clusters. Now, almost all cluster randomized trials allow for the invariance inflation at both the design and the analysis stage. So we're doing absolutely fine when it comes to allowing for the clustering, or the ICC. But reviews reveal that very few cluster trials make this degree of freedom correction, despite the fact that 75% of cluster trials have fewer than 40 clusters and so should be making this correction. So what can be done to fix this? Again, we're going to look at analysis methods in later sections. And we'll discover that not all packages implement small sample corrections for all models, but there are simple conservative adjustments which focus around using the t-distribution with 2k minus 2 degrees of freedom. And we'll learn more about these simple adjustments that we can make in future sessions. So in summary then, cluster randomized trials are often at risk of bias. Now, many of these risks of bias are common to patient randomized trials too, but they can be easily prevented. So prevention strategies include having a well-concealed cluster randomization method implemented, clear documentation of the outcomes. So essentially, we need to apply the same level of rigor around these two aspects as we do to patient randomized designs. Now, some of these risks of bias are difficult to navigate whatever the chosen design. So performance bias can be a concern even in pragmatic trials, and even in pragmatic trials using individual randomization. But other risks of biases are very prevalent in cluster randomized trials, and they're not easily mitigated when using a cluster randomized design. And the bias of particular concern here is to do with the identification and recruitment of patients or participants after randomization of clusters to treatment arms. And so for this reason, justification for choosing a cluster trial over a patient randomized trial can be very important, because this type of bias wouldn't arise in a patient randomized design. So here are the methods references that have been cited in this session. Here is the reference to one of the studies that was cited. And up next, we're going to think about when is cluster randomization justified.